Hello, welcome to the Integrated Care podcast from the Collaborative Family Healthcare Association. I am the production editor, Grace Pratt, PhD, LMFT, Oklahoma City, Oklahoma. And I am joined by an all-female crew of co-hosts today. We were just enjoying that fact. And we're actually going to have, I have this light and bubbly tone, but we're going to have a kind of a serious topic, as we do sometimes, talking about grief and loss and bereavement in integrated care today, which once again, I know I always say this, but I thought for sure we'd talked about this topic before, but I went through all of our archives and I did not see it there. So we're going to get there. But before we do, I want to start the way we always do with our introductions and our icebreaker question. And for our icebreaker, I would like to know, what's your favorite sweet snack? I know we've talked about road trip snacks before. That was a while ago that we had that icebreaker, but I had a friend here the other night and we were just trying a sampling of like different chocolate things from Trader Joe's. So we had the chocolate almond butter cups, and we had the chocolate covered orange pieces, which don't sleep on those. Those were amazing. But it made me wonder, what's your favorite sweet treat? So going around the circle the way you look to me, first we have Jen Thomas.
Okay. Hi, everybody. So I'm Jen Thomas, family medicine trained physician, Morris Hospital, integrated care provider, doing mainly the collaborative care model where I am in my neck of the woods. So hello and good to see everybody. Favorite sweet treat? That's a good one. I think I'm going to have to pick an oldie but a goodie. So my best friend growing up, Lindsay, her mom made this fabulous recipe, a gooey butter cake. I guess it's a St. Louis thing. Are you guys familiar with gooey butter cake? If not, you need to be. It's the most indulgent, like stick of butter, yellow cake mix, block of cream cheese, like I think even a pound of powdered sugar. I mean, it's awful listing off all the things in it, but it comes
amazing,
together
though.
in a glorious, divine baked gooey experience. My kids love it, and we make it a couple times a year, and it's definitely an indulgent. But yeah, check it out, gooey butter cake. It's good and bad.
As all the best sweet treats are. That sounds
Indeed.
Delicious.
It's great. Give it a shot.
Next we have Bridget just stuck a link in our chat like a boss. We will put that in the show notes. Next we do have Bridget Beachy.
I'm Bridget. I'm a licensed psychologist by trade, work as a BHC, director of BHC, consultant, other things. So as far as indulgent treat, definitely anything with excessive peanut butter sauce. So I don't, I try to stay away from desserts other than like frozen Cool Whip. That's like, anyone eat frozen Cool Whip? Like kind of
never had it.
Yeah,
is it like
good.
ice cream?
It's good. It's good.
You got to get your mind right that it's not going to be ice cream.
If you haven't had ice cream in a really long time, then
you could
probably
pretend
it's like ice cream.
Yeah, it's like any type of alternative. It's like, oh, it's like this, but not quite. You have to get your mind right and not expect it to taste like that thing.
Yep.
But I do enjoy a little bit of frozen Cool Whip. But as far as like the indulgent treat, if you get, like when you go to Dairy Queen, you get like a Reese's Blizzard, but ask for not only extra Reese's pieces, but ask for peanut butter sauce or extra peanut butter sauce in my case. So they have like literally a peanut butter sauce thing that they just like pour into that. So just each bite is just a lot of peanut butter mixed with the ice cream. So it's
nice. Oh, I have to give that a try. My oldest, she loves peanut butter shakes, the milkshake. Peanut butter milkshake's her thing. So that's right up her alley. That's great. I'm giving it a shot.
Sounds delicious. I'm a big Reese's person. I have to hide them from my kids if I want them to last, because I have spawned some of my own Reese's lovers. And so pro tip, you got to have a snack drawer that's away from all of the children that they don't access. Next, we have rounding out our crew this morning, Monica Williams Harrison.
Yeah, I was going to say snack drawer, but then you have to be careful. Don't let them hear you rustling anything. Monica Williams Harrison, licensed clinical social worker, integrated care lover, clinical trainer and practice coach with the University of Washington Ames Center. And I am a cakes, donuts type person, but my latest kind of sweet treat indulgence has been the cinnamon rolls. It's like the TikTok cinnamon rolls. Oh my gosh, y'all. Like
Are they
it's
the
the
ones that
best
you
thing
do in a
since
waffle
sliced bread.
iron? Or which TikTok
No,
cinnamon
like,
rolls are
so
these?
you get the cinnamon rolls. I can send it to you, but you get the cinnamon rolls. Basically, you're putting them in the dish, and then there's like heavy cream that you're pouring in there. So you're baking it with the heavy cream. The way they come out is almost like the Cinnabon.
Yeah,
Cinnamon.
I can smell it, Monica.
It's so amazing. But I had to look at a couple different TikToks because I like to make extra icing because I like the icing. But it is, oh my God, like I'll never make a regular cinnamon roll ever again in my entire life.
Game change.
That sounds
Yes,
delicious.
game changer.
We'll have to put that, our show notes are just going to be a list of recipes.
Yes.
This is actually a Pinterest episode, not
right. Surprise. Change of plans. There is a ice cream shop / cookie shop near here that does like kind of custom ice cream sandwiches. So you pick your top cookie, pick your bottom cookie, and then pick your ice cream in the middle. And also they deliver. So it's like, it's a bad good thing.
Too accessible.
It's too easily accessible, yes. But it's funny because I've been getting, I'm not making this up, gooey butter cookies on the outside with peanut butter, chocolate, ice cream. And
we're so aligned. Look at this. Even in our snack sweets.
If I could throw a little cinnamon roll on
you can be a little cinnamon flavor. There's cinnamon flavor ice cream.
Of all of our snacks. So next time you all come to Oklahoma, we will go to Baked Bear and have gooey butter, peanut butter, chocolate ice cream cookie sandwiches. And yes, I did say it's 22 degrees and windy outside this morning, but that does not rule out ice cream. Oh my gracious. Okay.
I think the colder states love ice cream.
Right?
Oh yeah. Anytime.
Yep. And although Neftali wasn't able to be with us here today, he did send over a little bit of news and notes. And so let's listen in on that. And thank you, Neftali. And now we'll transition into our main segment. So not to bring the mood down too far, but longtime listeners of our show will know that my mom, who I was very close to, was diagnosed with pancreatic cancer in 2018 and died in February of 2020. And yesterday was the 3-year anniversary of her passing. And so grief and loss and bereavement have been very much at the center and the forefront of my mind. And I was thinking about how frequently when we're working in primary care and in medicine in general, these ideas of loss and bereavement and grief come up much more than I ever anticipated, even working as an outpatient therapist. Of course, people come into therapy who are grieving, but it's such an intrinsic part of life. And when we come alongside people in this larger space of their life in medicine, it's bound to come up. And so I thought that it could make a rich conversation for us to talk about. How is that presenting in integrated care? Let's have a little bit more of those like practical on the ground for clinician episodes today. Opening in that way, I wonder if anybody has some kind of general thoughts to share about grief and loss and bereavement in integrated care.
Yeah, I have some general. I do remember when your mom was passing away. It was around the same time that my dad was as well. One of the things that I oftentimes trying to get individuals to realize who are part of an integrated care team is that grief and loss is more than just death, right? Like family members or someone in your life that has passed away. Like there's grief and loss that happens from a divorce. There's grief and loss that happens from the loss of a job or transition, your kids going off to college. Like there are all of these different ways that grief shows up that we don't always think about. And I think it is easy in primary care to only focus on, they're grieving when they've, like a family member or somebody has died, and not think about these other life changes and transitions and things that happen that come with a component of grief to them, because it's a loss, right? And sometimes it's a positive thing, like your kids going off to school is amazing, like, whoo, You are halfway there because you're not done, but you're like, you are on the road. You have helped them succeed, but there's still a loss that comes with that. And I think that it is easy to overlook how some of our patients might be handling that or experiencing that if we're not aware of other symptoms and things that come up for people who are experiencing grief and loss.
Yeah, and I think it doesn't always start with a patient being like, "Hi, I'm grieving," or does it ever? I mean, maybe we see someone who's like in that immediate aftermath and is panicking or having trouble sleeping, and they come in. But I think much more often it's running through the background of someone. And, we talk about the dangers of our screenings. And this is, one of the things I wanted us to talk about, like, how do we acknowledge and honor the space for grieving, but without pathologizing it? Because what are the symptoms of grief, and loss? You can't sleep right. And maybe you don't feel hungry and you don't want to eat, or you're distracted all the time. Like, it described like a 9 on the PHQ 9 already right there with those items, right? Or feeling hopeless, or even, for many people, especially who, if it is because of a death of a loved one, they do think more about dying or even wish they could die to go be with that person. But that is not an expression of suicidal ideation. But depending on how someone's reading those items on the screener, they could be like, yeah, I think about it dying every day. So we need to bring so much nuance into this conversation and to recognize that I think sometimes when we're like, oh, PHQ 912, there's some depression going on here.
That's why,
I'm happy we're on video now. And I hope that someone is watching this on YouTube, because the way Bridget just rolled her eyes.
although they won't
Bridget
see
always gives us the nonverbals. I'm just saying.
they won't see it unless I'm saying something though, because of the way it's like,
Oh, that's true. Well,
whoever's
note for
talking.
the audio, Bridget
So
is rolling her eyes.
I'll have to make like a yelp and then roll my eyes. Yeah, I mean, that's why I actually think it's harmful in our field, and I'm so sorry, but I'm just gonna say stuff because I always do. And you guys haven't fired me yet, so until then, till you ask me not to come anymore, this is what y'all gonna get. That's why I never start with symptoms. I don't even ask people what they're coming in for. I swear on my life, I don't ask people about their symptoms at all. And you might be thinking to yourself, that's crazy. Bridget is a clinical psychologist working as a BHC in a primary care setting, having primarily 25-minute visits. What do you mean you don't ask about symptoms? Well, because I ask about the context, and then they tell me the symptoms. And so you have to know them as a clinician. But yeah, when you start with who you live with and what's your relationship and your family, those are the first 3 items of the contextual interview. They tell you everything that you need to know in a very short period of time. I mean, not always. I know that that was like a big generalization, but if somebody isn't sleeping and whatever with the PHQ, it's at a 12, I never come in and say, oh, well, your PHQ is in the moderate depression zone. Let's talk about it. I'm like, all right, hey, I see that, we got some high scores going on. I'm just kind of really interested in what's going on in your life right now. Is it cool if I ask some questions to get to know you and your situation so that we can come up with a plan that will be helpful today? And they're like, sure, that's it. Then boom, right into, all right. So, who you living with right now. And then once you do that, the stuff comes out. And never, y'all, make an assumption whether or not if somebody did die, say, oh, I'm so sorry. Find out how the person feels about it first, because the amount of times I've said something like 2 or 3 times, I guess that's all it took, to be like, oh man, that's so tough that you lost your husband. And they're like, no, he was extremely abusive, X, Y, and Z, blah, blah, blah. So I learned that lesson after like 2 or 3 times of saying that, to just have the person tell you how they feel about it.
Yeah, that's great. I love hearing you guys talk about this from your BHC behavioral health background, because from the physician background, it's like, we needed so much more of this training. Like it was, a session here and there on grief and, oh yeah, it's normal. But I mean, ill-equipped is how I feel a lot of the time. It's like, yes, we know that's part of life, but there's also this vein in medicine of death is the failure, right? We screwed up, we didn't do something, or we neglected something. So it doesn't have it's natural, we should expect it, process it. So it is tough, I think. I mean, as much as I intellectually like, yes, it's part of life, and sitting with patients and sitting with them with their pain, it makes sense. Then there's all the other stuff in primary care of like, okay, but we're 3 patients behind, and you're like, how do I tackle this with empathy and be present with this person and juggle everything else that we've got going on. So wish we did a better job. Wish I had more training in just the knowing, and even what's normal versus complicated. I mean, even that pathologizes it, right? Like, well, what's normal? Is it normal for you to be this sad a month out, 3 months out? Is it now a disorder? I mean, in medicine, we're very, checklisty DSM, right? So it's like, that doesn't, I don't know, it doesn't serve us well, I don't think, when we have that lens sometimes.
I agree, because who is to say what's normal for this person? And grief, like many things, is not linear. And so I think that's another thinking error that medicine tends to make, that like, okay, well, you have done your time in grief, you're feeling better. Great. We can check that off your list. Time to move on. But grief is not like, there may be exacerbations, but it's not like a time limited bound process. And someone can feel a lot better and then have an anniversary or have a reminder or have something else going on in their life that then complicates things. And I think a big piece of even helping patients walk through grief is doing some psychoeducation about this and helping them understand what a grieving process looks like, and that it is normal to have these waves. It's not to say that they shouldn't ask for help or that they shouldn't experience that pain or reach out when they have it. But also sometimes just knowing like, hey, you're not crazy, and it's okay that this is still painful months, years, however long out that it is, I think can be really comforting for people. So a lot of what I do when I'm talking to someone and we identify that there's been a loss or that they're experiencing grief is ask them about their expectations and of grief, and or how did they see people in their family grieve, and how did they experience that, and provide a little bit of information about what we know about grief from a little bit of a scientific standpoint that then they can process.
Yeah. Grace, I think you hit the nail on the head about helping folks to not feel like they're crazy or that they're always going to feel this way. That's a big part of the work that I feel that I'm doing on a regular basis when it comes to grief. It's just like, I mean, most of the homework is feel like shit because this is a really shitty thing that happened. And that permission to feel difficult. And, that's my translation, because I know, like, I come from an ACT conceptualization, which is about acceptance and willingness, but you don't go to somebody and say, like, accept it and be willing to experience the pain. The pain is a reflection of how much you love the person. I mean, that's our academic, and then translating into
You could
everyday
do
life.
it and they probably would cuss you out, but you could do it.
You could do it. I recommend translating that into, okay, yeah, you feel like shit because somebody who's really, really important to you died or transitioned or whatever was going on. And like, that would be weird if you weren't having difficulty. So yeah, we should expect to feel really, really terrible. So I think we should just feel that way. And they're like, what? And you're like, because every other person in their life has told them, think about the bright side, remember the good times, blah, blah, blah. And we're giving them a completely different experience. And that in and of itself, I've found is what 90% of people need, is just that.
It's also such an argument for keeping our focus on the functional, right? Like, how is this impacting your life? Because it is okay to feel really terrible. And of course you do. And then sometimes you still have to go to a job and provide for a family, or you still have to try to be present for your kids, or you still have to record a podcast. And so like, how do you walk that line of finding that place where you're functional and meeting those goals that you have and needs that you have in your life, which I think is a big part of, it's not about the symptoms, back to what you were saying at the beginning. It's about the life that someone is living and what's important to them and how that aligns with the bigger picture of their health and their community and their family.
Yeah, I think if you focus on that, it also, there's always been, at least for me, in a lot of the places that I've worked in and spaces that I've been in, this kind of almost like there's a time where it's just supposed to stop, like you're not supposed to feel it anymore. And, so I've had been a part of a team and had colleagues say, well, that was 3 years ago. Like, not like this something's wrong with this person. That was 3 years ago. Why are they still talking about this? They are obsessed, right? So just thinking negatively and putting a time frame on it, which is why I like the idea of focusing on the functionality. How are they functioning? Because there is no real time, like, well, you tell somebody else how long they're supposed to be grieving or, experiencing something. But it's challenging because I do think that we are in a field that historically is a fix-it field. Healthcare, someone's sick, you fix it. Someone's feeling this, you fix it. They have these symptoms,
Yep.
you fix it. And so I think it could be challenging to it's almost like sitting with it. That could be challenging for some individuals on a part of an integrated care team.
Mm-hmm. Mm-hmm.
Yeah, I agree, Monica, so much that with trainees, there's such angst about like when somebody else is when the patient is distressed in the room of like, well, what am I going to give them? What am I going to do? And it's like, you ain't going to do nothing but sit there and be with them and hear it. And the cool thing is if you come from a contextual lens and you're able to learn about this person who died and you're learning about this person's life, right? Like the patient who comes in and you're learning about their life and how things work out. And then you hear that, okay, my kid died, or my mom died, or my brother died. But you at that point know that they're a really super tight-knit family and that this was the second of 4 kids and they're the third of the 4th kids and the 2 of them were the closest. Once you know some of these dynamics and you as the clinician are like in their skin, right? You're like seeing things from their lens, you're living in their world. When you go to say, oh my gosh, that sounds terrible. Like your heart must be broken. They're like, somebody gets it. Whereas if someone just says like, oh, what's going on? And then, I've been having headaches. Oh, when did the headaches start? Well, my brother died 2 weeks ago. Oh, I'm so sorry. It's like the second one is like an academic exercise. It's like, oh, I'm so sorry. And they might be really well intentioned. They might really feel sorry that their brother died 2 weeks ago. But the best way for a clinician to feel what the patient is feeling, to a certain degree, of course, is to know the nuance, like Grace was saying, the nuance behind it. So then when you say, oh my gosh, I'm here with you, it's actually the reciprocity, like your mirror neurons are going crazy with the patient. They feel that you get it, and that is the intervention.
That's so wise. Yeah. I mean, I think impulsively with the medicine, it's the fix it, Monica, right? Like, I'm supposed to go in there and do something for you, give you a pill or give you a whatever,
Go on
something
and prescribe
tangible.
that gabapentin.
Right.
Thomas.
I mean, that's as much as I'm trying to unlearn that with all this great influence that I'm learning with all this integrated care stuff with you guys these years. It's really cool just to hear. It's like, you don't have to go fix it. You just sit with them and listen. And I think a handful of times I've touched on that and like realized like, oh wait, right. I just sit and listened to him talk about his wife that he loved. And, I didn't give him a pill, but he said, wow, that was really helpful. And he came back and we talked the next month. And it was just very eye-opening and surprising that even as a medical provider, you can help someone in that way just by listening. I mean, I just feel like that's something we should just spread around to all the, new trainees of like, yes, Bridget, your point 100%. Just sit there and listen. I mean, I don't know. That's so helpful. So freeing.
I'm sorry if anyone heard this crash and Bowser is living up to his name, my cat. It's funny because sitting and listening and connecting, like those are all the central part of what we offer. And the relationship is still the tool of the connection. And there are some things that I find helpful that come up a lot. So for example, sleep, like these patients a lot of times can benefit some really specific discussion around sleep hygiene. And like, let's at least maximize the things that you can control to improve your sleep, because grief is affecting it so much already. The other thing is that grief can be so culturally bound, and there's so many like rituals and rites that help people move through that processing. And so opening space for them to talk about what does grief look like or bereavement look like in their family and in their culture. And the idea that a ritual is just a routine that you do with a meaning behind it. And they can develop anything that can be a ritual. And maybe there are some that are prescribed in their family. Maybe they, whether it's family or cultural or religious based, but they also can make up their own. And I think that is a pretty powerful thing that I don't know that we talk about it in that language very overtly, culturally, or in the larger conversation about grief. And so being able to present that to someone and encourage them to think about what would be meaningful to them as they process their loss has also been a really helpful conversation for me a lot of times.
That's awesome.
would you-
Teach me more about that. The ritual, is that like a honoring their memory, like it's an anniversary? Like how would you help someone with doing that?
I tell people it can be literally anything. So a ritual is just a routine. So it needs to have some kind of sequence of steps and with a meaning attached to it. So it could be that they go to a place and eat a breakfast where they used to have it together and share those memories in that space, or take a loved one with them. It could be that they bake a favorite recipe. It could be that they write a letter and burn it. All of these things are examples of rituals. And we have some that are, commonly done, like funerals or rituals or burials, sometimes are rituals. And again, there's differences based in culture and things like that. But any specific like meaning and intention that someone's attaches to a specific like routine or behavior can be a ritual. And if they do it repeatedly, that can be meaningful to some people, versus some people they just need to do it once. But it's helping. I'm seeing in the comments, Monica and Bridget agreeing about this. So I'd love to hear more of how you've used this or how you find it helpful.
Yeah, I think rituals are really important for multiple reasons, right? Not only sometimes to provide some comfort to individuals, but I think about there's some cultural implications sometimes for some rituals. And I always want to know about that for the person sitting in front of me, because sometimes we get into the habit of kind of almost using the same intervention or suggesting the same thing to a patient, and it might actually go against some type of cultural ritual, right? So I have been in a space, and will never name anyone or what space it was in, but I've been in a space where an individual was having a really hard time with a death. And the recommendation that was given to the individual was, oh, well, if you don't want to go to the funeral, then just don't go. Just don't go. However, that actually caused more stress for this individual, because it was the family's ritual. There's a wake the day before, and you got to greet people for 2 and 3 hours. And then you go to the funeral, and that's 2 or 3 hours. And then you go to the it was a family religious ritual that, even though the individual didn't was having a really hard time, the thought of not going actually caused them more stress, because now it's like, what's the family going to say? And this is just what we do, right? And although sometimes the things that we do, it's like, you ain't got to do it. But if it is a ritual, and it depends on how that individual feels about it. And I think that we oftentimes don't ask that. We don't ask, and then we don't know what some of the cultural implications might be. And we go straight into suggesting things that go against some things that are a sense of normalcy, even in a weird kind of tough time for some of our patients.
Yeah, I mean, I think that we're really coming onto this. It's about the approach that we're coming with a patient from, switching from, well, let me tell you what to do, to being more inquisitive about what's going on. What's, and like Grace was saying, what's the biggest difficulty for you right now to be able to get through your day? Oh, it's my sleep. Okay, would it be okay if we talked about that? Or when we're talking about the rituals, I mean, a really simple and easy thing that any clinician could do at any time is literally just ask the patient, is there anything that you do to honor or remember the person? Is there anything that you do that comforts you or helps you to feel close during this time? It doesn't even have to be like, worded nicely. It could just literally be like, well, is there anything that you do? As long as you literally are genuinely curious. The amount of folks, I used to think I had to help them come up with the ritual. You don't have to help them come up with a ritual in most cases. Most of the cases, they already have something.
Yeah, we just didn't call it a ritual. That's so great, Bridget. I can think of a patient. She sewed me a cute little crocheted cross ornament. She died of pancreatic cancer. It's on my Christmas tree. And every time we're decorating for Christmas, I'm like, oh, May made that. That's a ritual, huh? Look at that.
Yes, that is 100% a ritual.
Okay. Oh, that's great.
Yeah,
And
they
it
might have a
is.
locket or
Yeah.
a photo or
Yeah.
something.
Okay.
Yeah. And it's about the meaning that we attach to it,
Okay.
because a ritual gives you a conduit for those emotions. And, you know, if it happens communally, like with a funeral, like Monica was talking about, or other kinds of, right now, the ritual that's developing in my family is my mom had a recipe notebook, and it was like taped together, all these like cut out of magazines, handwritten, there's grease spots on it. And so I have been holding it, and for Christmas this year I had it reproduced, and I gave it to a copy to my brother and a copy to my dad. And now every time one of us cooks something out of the cookbook, we send the page number and say, oh, this recipe was so good. And like, even that is becoming a little bit of a ritual
Yeah.
for us, and
Oh,
a
that's
place
great.
of connection. So it's about this sort of honoring and moving through, because it touches too. And I'm really glad that you brought up that example with your patient, Jen, because the more ambiguous our loss is, sometimes the more complicated that grief is to process. And there aren't a lot of scripts for how we as healthcare providers should deal with grief and loss of our patients or the people that we work with. And so there's another concept in, you know, psychology about disenfranchised grief. And it's kind of this disconnected, it's these grief feelings that are floating around, but there's not really a particular outlet or a path for them. And I think that happens to us as providers because we're not the family of these people. We are not in their inner circle necessarily, but we build relationships. And our doctor-patient relationship is not just about the patient's relationship to us. It's also about our relationships to the people that we're taking care of. So I'm curious if or how you guys have experienced these feelings of grief and loss around the patient care that you do, or how have you seen that on your teams that you've worked with, and how do we deal with that?
That was the surprising aspect for me. I wasn't like, when going into integrated care, I had not thought about, if you're working with full spectrum, a lot of times you're working with folks with, you know, chronic conditions. And so having patients die like kind of regularly, that was a shock to my system. Whereas our medical colleagues, especially our folks that are at the hospital, this is like every day for them. So it was like, I'm like, oh my God, my patient died. They're like, well, yeah, I had 3 patients die last week. And you're like, oh, like, I mean, they weren't, you know, not in like, you know,
No,
nobody
but
say anything mean or anything, but it's a different, so
yeah.
yeah, I'd be really curious from Jen's perspective.
I don't know. I wish I dealt with it better. I feel like I do have some level of avoidance where there is that fix it mentality and the like, you know, even in like documentation, you're always drilled in with that, like, you know, malpractice. What if you get sued? What if they die? You know, so I don't know. I don't think it's necessarily a healthy culture for us. I like that. What was it? Disenfranchised grief, where it's floating around. Totally. That's totally us in medicine, right? It's floating around. We don't know where to put it, or is it my fault, or is it, am I doing it right, or whatever? Absolutely. I think that's 100% our culture. And it'd be great to know how to cope with that and direct it somewhere healthier. And I don't know how to do that. I'd love to learn. So,
I
yeah.
think it's I don't know, it's hard. It's hard. And I think, of course, everyone deals with it differently. I used to work in nephrology, where we were, you know, team approach, and we had some patients who passed away a lot. And so then not only did you start to become a family, especially with the dialysis patients, because you're seeing them 3 times a week for 4 hours, and you end up being like this other extended family. We used a lot of humor that maybe some other people didn't understand, our dry humor, but it was what worked for us, that, you know, of that team that I was on. And I think different patients hit you differently in terms of how you handle it and how you respond, you know. And so I think if you cry about a patient, well, you're human, like you're
Yeah.
okay. You ain't gotta beat yourself up because you're upset your patient died.
Yeah.
Like,
Yeah.
you're human too. And I think we're so hustle, and I mean, we're primary care, right? Like we're rocking, like we're in and out with patients, and then you get a message from front office like, hey, the police just came by to confirm that such and such was a patient here. Well, what happened? Well, they passed away. And now there's still like 4 patients for you to still go see. But
Yep.
now you just found out you lost this one. Like it's a lot. And then I think if you tack on, I want to imagine for our primary care providers, like, oh, well, they died from something medical, right? Then you're like,
Mm-hmm.
did
Yes.
I miss,
Yes.
like, did I miss it? What,
Yeah.
you know, like I'm sure that
Yeah.
would run through the
Ugh.
mind.
Yeah. And for me, it comes up at inopportune times where or not inopportune, I'm human, but it's come up at times where I'm like, dang it, I wasn't in control. Like I didn't see this grief coming. I can think of watching the PALS class. They have a video on if a child dies, and how grief would be for the family. And I was taking that class a couple years ago, and I'd been hiking Colorado with my friends, and a gentleman died of cardiac arrest on the trail. So like someone went to get an AED and he was gone, but we were doing CPR, and it was really traumatic because it was outside of the hospital experience. And the crowd was like, oh, well, you're a doctor. And I'm like, yeah, but that doesn't mean I can save this man. And his son was there, and it was really awful. And process that. But then months later, I'm sitting in PALS and they're talking about if a child dies. And here I'm like, here come the tears. I'm hyperventilating. I like walked out of the room and what is that? I mean, I was very uncomfortable with that, but I had some awesome nurses that maybe, have dealt with that more, or they're more seasoned, and they're like, oh yeah. And then they told me their story. Like, yep, I can think of that one case, that kid that died in the car accident. That always brings up for me. And it was just very validating. Like, okay, you're human. You're going to have those, whoa, where did that come from? It's okay kind of experiences. So, yeah. And I don't mean inopportune. I guess it's just I need to just roll with that a bit, right? Like let that wash over you. I'm like, okay, that happened. It's not, it's not a bad thing. Maybe it's a good thing.
And so much of our struggle sometimes comes when we try to avoid it. It goes back to a big ACT principle too. I think I've told this analogy metaphor on the podcast before, but it's one of my favorites. I'm always using it, so I'm going to say it again. Grief and anger and other uncomfortable emotions is kind of like if you're at the beach or you're swimming and you have a beach ball and you're holding it under the water, and like no big deal, it's a beach ball, it weighs like a few ounces, you can hold it under the water, but like eventually the longer you hold it under the water, your arms are gonna get tired, and then your hands are gonna slip off, and it's gonna come up and it's gonna smack you in the face, and it's gonna hurt, and like it's gonna not be great. But if you can learn to kind of let the beach ball up in a controlled way, you can rest a little while and then you can put it back down, and it stays a process that you feel like you have some competency, like some I don't know what the word I'm looking for, but you feel like you're in control of it. And we can't always be in control of our grief, and we can't always be in control of our strong emotions. But if we can learn to let them to the surface, sometimes intentionally in a safe place or a safe context with those people who are safe in our community, then we can have the strength that we need to, sometimes when we need to refocus or we need to get back to the task at hand, to put them back down under the water for a little while, because we know that we can let them back up. And I think that comes with, to translate it, comes with, if we can let ourselves experience it or learn to have that comfort in letting the grief come to the surface sometimes, then there will be less of it smacks you in the face in the middle of nowhere. Now that still sometimes will happen, especially like the closer to home it hits. Sometimes somebody comes and pushes you from the behind in the pool and your arms slip off, and it, whatever. This metaphor is getting driven into the ground, but it helps to have some of that controlled release. And that's where it ties back into like compassion fatigue and burnout for our providers too, that there's a place for that medical humor, that dark humor, but also I think it can turn into like a real jadedness or a real disconnection from the reality of the emotions of the situation. And so it can be a harder line to walk.
It is. Yeah, I like that. I love that though, the beach ball, letting it come up and down. That's great. Thank you.
I love that metaphor. I use it all the time.
It's a good one.
I know I've said it before, but And you spoke to the power of community and hearing those stories from those nurses. I think that makes such a big difference when we have a trusted person or safe people in our circles that we can talk to. And hopefully we're building this on our teams, right? Is this something that you guys have experienced from a team standpoint?
We haven't done a
Actually,
great job.
no.
Yeah, I was gonna say
Wow,
we haven't done
okay.
a good job at all. Like when we find out somebody dies, we're like, oh God. And then we like,
And we move on.
yeah, we move
Same.
on.
Same.
Yeah.
And there's a deceased marker at the top of their, how dehumanizing is that in our EMR? Deceased, and they are, it's the way to categorize it, but it is just a label and move on. I mean, I don't know. We don't process it as a team ever. We should.
I think maybe we have some opportunity here.
Yeah. Yeah. I mean, it is definitely something to think about. How are we going to process? And I was almost going to use the word debrief, but that sounds so formal, but we do nothing, so it's almost like everybody just like you just go on with your day. You got more patients to see, and patient in room 4 needs you, patient room 6 needs blah, blah, blah. Like, like we go on. I've not worked anywhere yet on a team where we've had a real plan or discussion around what we would do when we find out some of our patients have passed away.
Grace,
Even in dialysis. Like, I'm like, wait. Yeah.
Grace, I'm like now thinking about, because we are residency as well. And I'm just realizing that we talk about the academic topic of grief and the rituals and the contextual approach and all that, but we don't, and we like offer like support, like, hey, you can come talk to me, but do you guys do anything to help them to actually process the residents?
Yeah, they don't always love it. I force them into rituals as often as possible. So we have a monthly resident support group that meets, and in that group, we talk a lot about lots of issues facing the residency, but like even yesterday, when we talk about hard cases, one of our residents was bringing up a patient who is approaching the end of his life, who he's worked with really closely, and it's just kind of a sad situation. And everybody was telling him, oh, you've done everything you can. You've done everything you can. And I stopped the conversation and I was like, I think Mason knows that he did everything he can, but I wonder what it looks like for us to just hold space for the grief of this. And I used it as a little teaching point of, disenfranchised grief and the things that we're talking about today. But so ours come up in that resident support group every month. And then also I do some medical humanities work with them also in terms of like reading and responding to short narrative pieces or poetry that have been published in JAMA, or Family Systems and Health, and Family Medicine even sometimes publishes some of those pieces. To varying degrees of acceptance, depending on how cooperative they're feeling. But for the most part, I have a pretty good relationship with them, so they'll humor me, even if they don't feel like doing it. And I do, like right now, we're actually reading in small groups When Breath Becomes Air, a memoir that was written by a neurosurgeon who got lung cancer. And so it's sort of this duality of a patient memoir and a physician memoir. And I'm making them talk about it. So we do. I don't know, what it's going to be so system dependent. And I think for us, it's about, or for me, it has been about identifying like, where are those pockets of time that we have the space to have this conversation, and how do I just keep bringing it up over and over and forcing it to happen.
It's funny for you to be like they have some resistance.
Yeah.
I can see it in my head, but you're planting a seed, right? Like
you
are planting
you
the seed.
You are.
And they honestly, they do humor me.
Yeah.
And I think sometimes they're like, some days you feel like going there and dealing with the emotion mess of it, and some days you don't. And they're both okay. But I know I try to give, so this is again a little bit from an education standpoint or a leadership standpoint, I try to give multiple different opportunities. So like, sometimes it's like, let's have a really deep conversation about this, versus sometimes it's, let's do something like a little bit lighter or a little bit more reflective internally versus talking about it externally. And so whether someone's a verbal processor or a, internal thinker or whatever, I try to make lots of different opportunities for them. And it blends. It's not always specifically about grief and loss of our patients or, how that affects us, but just this larger, we talk about self of the therapist all the time in therapeutic training, all the time. Self of the therapist, self of the therapist, self of the therapist. Nobody says self of the physician. So I do. I'm like, well, this is yourself as a physician, and this is what we're going to talk about. And, they hate to love me for it, but we
Jen,
get there.
did you get any of this?
That's so interesting you were bringing this up, and I think someone was commenting about this just yesterday on the listserv about Valent Group. Is that similar? Okay, in my residency, and we were small, unopposed, we had like maybe 10 residents, we'd be like, I roll, it's Valent time. And I apologize, I think his name was Tony. He was a lovely social worker that was like super into it, and we were all like young, stupid, like, oh, talk about feelings. But planting the seed, Monica, like now 12 years out of training, I'm like, that's a thing. We should do that more. We need to get Valent Group going here. So, and it just, maybe it just took us that while to realize, hey, this is a good thing. But no, I mean, Grace, not to like, poo-poo your hard work, but I mean, some of us, leaned in and participated, but sometimes it was like, oh, made us uncomfortable. We didn't want to talk about the challenging things. So we kind of did the avoidance of like, oh, it's Valent Group, like who cares, But no, I think it was important, and I'm glad they exposed us to that. And heck yeah, I'd be a 180 right now. And wherever you are, Tony, thanks for teaching me Valent. Not that
Jen's like, shout out Tony. Sorry, Tony.
I think his name was Tony. If it was Tim or something, he's going to be like, dang it, Jen. But anyway, thank you.
I just keep showing up and keep making the space, and when and if they want to engage, they can. And ultimately, like that's our division of responsibility. I create the opportunities, and then they can choose to engage with it.
That's great though. Live and learn, I mean, you don't know what you need maybe when you're young, starting out as a clinician, and you start practicing like, oh, okay, there's definitely a need for that, and make space for that. Absolutely.
And what's funny, because I think the WWAMI had done some research, some folks in the WWAMI network, which is like Washington area, and Alaska, Montana, Idaho, I think. Anyway, the behavioral scientists got together and like polled basically like what folks like in residency, what they wanted less of and more of, and then like 10 years later, what they wanted less and more of. And it's like over and over and over again. It was like, I didn't want so much behavioral health stuff. And then 10 years later, it's like, what did you want more?
More.
All, behavioral health stuff. So, which it makes sense, when you're in training, and Jen would know, I don't mean to like talk for you or like,
no, go for it.
Physicians explain you or something right now.
No, all good.
You're trying to get competency down with like some major things. Make sure you don't kill somebody. Make sure you don't get embarrassed by your preceptors, and some of the other more nebulous stuff, it's a little bit harder to pin down. So you're like, oh, we'll deal with that later.
Mm-hmm.
And then there's also you can point to, I've done 47 C-sections or whatever, and it's a number.
And there is,
compared to I dealt with grief in my patient care.
100 times, 1,000 times.
Nobody needs credentialing for that, although maybe we should.
We should.
I know. I mean, we honestly made like the basic skills assessment, the BSAs. We did one on the contextual interview. Like, can you?
Oh, I so should have learned that. I'm like listening to the PCBH corner stuff. I'm like, I need to learn how to do that contextual stuff she's talking about. Because I think about residency. I had to do 2 toenail removals, and I'm like, ew, like I never did a toenail removal after residency. I hate that stuff. I'm like, was that a good use of my time? Heck no. I should have been learning contextual interview instead of basic podiatry.
For all of those of you who feel like you still need to learn things, here we are. And we all are, right?
Well, I learned about disenfranchised grief. I didn't ever put that together. And I learned on this episode about like, we have definitely some area of opportunity in our residency and within our just like clinical teams, both aspects.
For sure.
I love it. It's so fun. I think sometimes when we get to do one of these, a little bit of a how-to episodes and get really practical about what that looks like. So I'm so happy to have had all of you here with me today. And we are going to have From a Distance closing from Deepu. Thank you guys. Thank you all for being here. Thank you to our listeners, and we'll talk to you again next month.